Hello, welcome to another episode of Arthritis and You, a joint journey. Today, we've got something special lined up, so buckle up because it's time for the deep dive. Let's give a warm welcome to our hosts, Arthur and Sarah.
Have you ever found yourself maybe wading through medical websites trying to make sense of new treatments? Or perhaps you're just curious about how medicine tackles complex conditions? Well, you're in the right place. Today, we're doing a deep dive into a really interesting group of medications called IL-17 antagonists. They're used quite a bit in rheumatology.
Exactly. And our mission today is basically to pull out the key info from our sources. We're looking mainly at the Alberta Rheumatology website and their YouTube channel. Really good stuff there. We'll explore, what these drugs are, how they actually work, who they're for, and the important things patients and doctors need to talk about. The goal is to give you a solid understanding, without getting lost in all the heavy medical terms, just the useful bits.
Okay, sounds great. Let's unpack this then. IL-17 antagonists.
Yeah.
What exactly are we talking about here? Are they completely new, like a totally different kind of drug?
Yeah, good question. So they fit into this bigger family called biologics. And biologics themselves are quite fascinating. They're not like typical pills made from chemicals. No, these are complex drugs made from living cells designed to target really specific parts of the immune system. IL-17 antagonists are, well, a relatively new type of DMARD that's disease-modifying anti-rheumatic drug. So they aim to actually slow the disease down, not just mask symptoms. And while they are biologics, like, say, the TNF antagonists people might have heard of, they work differently. They target a very specific immune signal, IL-17, not the same as TNF blockers at all.
Right. That distinction is key. So they're more focused, maybe. If they work differently, how do they actually, function inside the body to fight inflammation? Can you paint a picture for us?
Okay, so imagine the immune system is like this incredibly complex communication network. Lots of signals flying around telling cells what to do. IL-17 is one of those signals. In certain diseases, it's like a signal that's stuck on loud, telling immune cells to keep causing inflammation, pain, damage, just generally overreacting. What these IL-17 blockers do is they specifically intercept that one signal. They block the IL-17 protein itself, so they don't shut down the whole immune system, just that particular inflammatory pathway that IL-17 drives. And the result, less inflammation, less pain, people can function better. It's about interrupting a specific conversation in that immune network.
That makes a lot of sense, like targeting the specific problem signal, not the whole system. Yeah. So who gets prescribed these? What conditions are they mainly used for?
They're most commonly used for ankylosing spondylitis, AS, and psoriatic arthritis, PSA. In those conditions, research has really shown that IL-17 is a major player, kind of driving the inflammation process. They're sometimes used in other similar inflammatory diseases, too, where IL-17 is known to be involved. So yeah, primarily AS and PSA.
Okay. So for someone maybe thinking about this treatment, or just starting, what are the practical bits? Like, how do you take it? Is it a pill, an infusion?
Good point. The how is important. These aren't pills. They're given as subcutaneous injections.
Okay, so under the skin.
Exactly, just under the skin. Many people actually learn to do the injections themselves at home. They often come in pre-filled syringes or auto-injectors, which makes it easier. Our sources mention three main ones. First, there's secukinumab, brand name Cosentyx. That one often starts with weekly injections for the first month, like a loading phase. Then it usually goes to once every 4 weeks. Doses are typically 150 or 300 milligrams.
Okay, weekly, then monthly. What about the others?
Right. Then there's ixekizumab or Taltz. That one's usually 80 milligrams, also every 4 weeks after an initial loading dose. And the third one mentioned is bimekizumab, brand name Bimzelx. Also a subcutaneous injection, typically 160 milligrams every 4 weeks, again, after a loading phase. So you see the pattern loading doses for some, then generally moving to monthly injections. People usually get the hang of it pretty quickly.
Monthly injections, okay. Now, how long does it take? If someone starts, when might they actually, feel a difference? Is it quick?
Well, it varies, obviously, person to person, but the sources suggest it generally takes at least 1 to 3 months before you really start noticing the benefits. Sometimes maybe a bit sooner, perhaps a few weeks for some initial changes, but it's definitely not like taking a painkiller where you feel relief right away. These drugs are working on the underlying immune process, calming that inflammation down, so it's a gradual thing. Patience is important.
1 to 3 months, right. So here's a question then. If you start one of these, say, Cosentyx or Taltz, can you just stop your other medications, like methotrexate maybe?
That's a conversation you absolutely must have with your rheumatologist. It's really decided case by case. Technically, yes, IL-17 antagonists can be used on their own without methotrexate or other conventional DMARDs. But, and this is a big but, usually the reason a biologic like an IL-17 antagonist is recommended is because the inflammation hasn't been fully controlled by those other DMARDs alone.
Right, because things weren't working well enough.
Exactly. So the goal is always the best possible disease control, getting that inflammation right down. Often that means continuing the other DMARDs alongside the biologic, at least for a while. Using them together can sometimes give a better result than either one alone. Your doctor will figure out the best strategy for you.
Okay, so combination therapy is often the way to go, at least initially. Makes sense. So beyond just less inflammation, what are the sort of real-world benefits? What improvements might people actually see in their daily lives?
Oh, the benefits can be really significant for people. We're talking about less swelling in the joints, which can be incredibly disabling. Definitely improvements in pain and stiffness, making easier to just move in the morning, get dressed, that sort of thing. Better day-to-day function overall, maybe being able to do chores, hobbies, work, things that were difficult or impossible before. And really importantly, thinking long-term, these drugs can help reduce or prevent irreversible joint damage. For AS, that might mean less spinal fusion. For PSA, preserving hand function, for example. That's huge.
That is huge. Protecting joints long-term is critical. Now, with powerful medications, there are always things to watch out for. What about side effects or other important considerations with IL-17 antagonists?
Absolutely. There are definitely key things to be aware of and discuss with your doctor. First, injection site reactions, redness, itching, maybe some swelling right where you inject. Usually mild, but if they're bad or don't go away, you need to tell your doctor.
Okay, local reactions. What else?
Well, because they affect the immune system, there is an increased risk of infections and potentially more severe infections. So things like fevers, a really bad cough, skin infections getting serious. None of that should be ignored. Call your doctor. They'll probably tell you to hold off on your next injection until you're better.
Right. Infections are a common theme with biologics, aren't they?
They are, yes. Another specific one is tuberculosis, or TB. If you've ever been exposed to TB in the past, even if you never got sick, these meds could potentially reactivate it. That's why, before you start, your rheumatologist will always do screening, usually a TB skin test and a chest x-ray. It's standard procedure, very important.
Okay, TB screening. Got it.
And here's a really critical one specific to IL-17s. Inflammatory bowel disease, like Crohn's or ulcerative colitis. Unlike some other biologics that can actually treat IBD, these IL-17 blockers don't seem to help it. In fact, they might even trigger flares or make existing IBD worse. So they're generally avoided if you have a history of IBD. You must tell your doctor about any gut issues.
Wow, okay, that's a major difference. Good to know. Anything else? Vaccinations, monitoring.
Yes, vaccinations need discussion. Specifically, live vaccines like MMR, the chickenpox vaccine, nasal flu vaccine should ideally be given before you start the IL-17 antagonist. You generally avoid live vaccines while on these meds. And yes, regular monitoring with blood tests is standard, just to keep an eye on things like blood counts and liver function. And always keep your doctor updated about any other health conditions or any new medications you start. It's all connected.
That's a lot to keep in mind, but really crucial information. So what if someone misses a dose? Or what if they need to stop taking the medication altogether? Do they need to taper off slowly?
Actually, no. It's generally safe to just stop an IL-17 antagonist if needed, or if you miss a dose and need to figure out timing with your doctor. You don't need to slowly reduce the dose. There's no physical withdrawal syndrome.
Okay, so no tapering needed.
Right. But the key thing to remember is, if the medication was helping you reducing your symptoms, those benefits will likely disappear, usually within a few weeks after stopping. The inflammation it was controlling will probably come back.
Right, the underlying issue is still there. Okay, so wrapping this up, we've taken a deep dive into these IL-17 antagonists.
Yeah.
We see they're part of that biologics class of DMARDs. And we learned how they work by specifically targeting that IL-17 protein, like that dimmer switch analogy, to reduce inflammation, help function, protect joints, especially in things like ankylosing spondylitis and psoriatic arthritis. It really shows how treatments are becoming more targeted.
Indeed. And knowing this stuff, understanding how they work and what to look out for, well, it empowers you, doesn't it? It helps you have much better conversations with your doctor about your specific situation and treatment choices. But of course, just a reminder, everything we've talked about today is for educational purposes. It's not medical advice. You always need to talk to your own doctor for that personal guidance.
Absolutely. So here's a final thought to leave you with. Given how specific these IL-17 antagonists are, targeting just one protein, what other ultra-specific pathways in our complex immune system might researchers be zeroing in on right now? How might these kinds of highly focused therapies continue to change medicine, perhaps leading to even more personalized treatments down the road? Something to ponder. Thanks for joining us for this deep dive.
This has been another episode of Arthritis and You, a joint journey. Brought to you by the Rheum team from albertarheumatology.com. Your trusted, evidence-based suite of resources available 24/7. Straight from Alberta, but for folks around the world. Our hosts today, Arthritis and Sarah Upis. Technical producer, John Eifel. And our executive producer, Stephen Cates. While we work hard to maintain the accuracy of our information, we accept no legal responsibility for any errors or omissions. Remember, always check with your own physician first. Join us next time for another Deep Dive.